approached Morphils for the trial which was going, but I don't think they followed up later on because they shifted probably there and they never haven't come back. But the child with achromatopsia, so parents are open to shifting out of India also to places where these clinical trials are going on and maybe enroll their children into the trials and await. But in India per se, crowdfunding for an ophthalmic disorder, I'm not aware of.
So Messi did that. So he migrated from Argentina to Spain, and then that's how he became a football player also, and he got funding to support. So I think it's a good thing if the government is doing. Thank you. So next, can I invite Dr. Vinay Gupta to give a talk? And Vinay Gupta, as I said, is the founding president of Indian Pediatric Glaucoma, and he's also part of the International Council of Ophthalmology with us. Thank you, Vinay. I should have your number. I lost your number.
Thank you, Shailja, for inviting me for this talk. I'm basically a clinician, but I'm going to talk about our journey in trying to investigate the genetic basis of certain anterior segment disorders. So as we all know, that what we know at present is just the tip of the iceberg. And in order to know more, a lot needs to be done. For example, for a clinician, it is about establishing the correct phenotype, the severity of the phenotype, to be able to get a good pedigree of that particular individual, collecting DNA samples from as many relatives as possible, trying to sequence them, interpreting that data, and then follow up with their penetrance and expression data. And this all requires a lot of time, money, and of course commitment to the cause. But then, of course, the return on investment is huge. I mean, even if you can help one family, I think it's a huge amount of work that has gone to some benefit. So I'm going to show you some cases of when we require genetic testing and when not. For example, this is a 10-year-old who came with a classic posterior embryotoxon, and it was an Axenfeld Rieger malformation, and we really didn't require any genetic testing for this patient because invariably it's either a FOXY1 or a PITEX2 mutation. This is another case where it is a classic case of aniridia, and if it is a familial case, probably we do not require much of genetic testing. Then there are these children who have a totally opaque corneas, typically central opacities with a when you do a UBM, you find this concavity in the posterior cornea, which is invariably a Peters anomaly. And again, really not much of genetic testing can help. But then there are certain situations where you need genetic testing to make a diagnosis. For example, in this particular case where we couldn't see a posterior embryotoxon, the iris was absolutely atrophied, and we really didn't know if it was a primary congenital glaucoma or an Axenfeld Rieger malformation. So we subjected the patient to a whole exome sequencing, and there was a FOXY1 mutation. But then there was a similar case like this where we find extensive iris atrophy, iris holes, a whirling of the pupil, and then again, you think whether it's an Axenfeld Rieger or primary congenital glaucoma. And here in this case, it turned out to be a CYP1B1 mutation. So the phenotype was, in both the first and second case, was almost similar. But of course, the genetic makeup in the two cases was very different. Then there could be situations where you want to provide the appropriate treatment. And this was, for example, a very interesting case when this young boy at 10 years of age came to me with very high intraocular pressures, and he was a high myope, and we thought it was juvenile open angle glaucoma. There was a corneal haze that he had, which was probably because of the high intraocular pressure. He underwent a both eyes trabeculectomy. 10 years later, after the trabeculectomy, his intraocular pressure rose again. In the right eye, it was like 27 millimeters of mercury, and his axial lens were normal, but his cornea was really thick. Considering the fact that his discs were relatively normal, we did a repeat trabeculectomy because we didn't want him to progress and become blind. Now he got married and he had a child, and he brought this child to me. The child had a very strange looking cornea, and this kind of corneal problem, I mean, I had never seen before, and my cornea colleagues were a little hesitant about what the diagnosis was. So here this child had a borderline corneal diameter. His axial lens were more or less normal. He was a high myope, but his corneal thickness was much more. So this was a time when we thought that a genetic testing is important to find out what this family had. We also did an IOCT of this child. This child was hardly 1 month old when he came to me, and of course the cornea was thickened. So it was not a case of CHED because it's not classical diffuse corneal haze that this child had. But on exome sequencing, it turned out to be a ZEB1 mutation, which is classically associated with the posterior polymorphous corneal dystrophy, and that is what both the father and the child had, and probably it was a mistaken diagnosis where the father was mistaken to be a juvenile open-angle glaucoma when actually it was a case of a corneal dystrophy, and he was subjected to 2 surgeries for glaucoma when it was actually not glaucoma at all. So here, a sequencing, a genetic diagnosis was important to establish what the phenotype was. Then again, there are certain disorders like this, for example, where you have thickened corneas, and in this particular case, the cornea was as thick as 1,000 microns, and this was a classic case of a CHED. But there are a lot of such children who are brought to us when the misdiagnosis between CHED and primary congenital glaucoma is actually a very borderline kind of condition, and some people think that actually both of them are exclusive to each other, that the primary congenital glaucoma is extremely different from a CHED, but then there are certain people who think that there could be glaucomas even associated with CHED. So then another important case I would like to highlight was of a young boy, another young boy who came to us. He had normal looking corneas, but they were slightly smaller but very high intraocular pressure with a high myopia. They don't give any family history of glaucoma, but you can see that there's an advanced glaucomatous optic atrophy in the left eye, for which we did a trabeculectomy. His corneal diameters were slightly smaller, and this child and his parents underwent whole exome sequencing, where we found a COL4A1 mutation, which is not classically associated with glaucomas, but has been found to be associated with posterior embryotoxin and an axon-field Rieger malformation-like phenotype. They're also associated with cerebral lesions, and it is known that these children, as they grow up, can have microangiopathy and stroke, in which case they require repeated MRIs. So when we went back and we looked at his gonioscopy, there was a subtle prominence of his Schwalbe's line, which was actually found out only on an AIOS OCT. So the MRI was normal, but now we went back and looked at the father, because all this time the father was said to have normal eyes and normal vision, but his father also turned out to have high intraocular pressures. He was an ocular hypertensive, and when we examined him carefully, he also had this posterior embryotoxin, which is extremely subtle. So this particular family actually gave us a new diagnosis, a new phenotype that could be associated with juvenile open-angle glaucoma, which is a COL4A1 mutation. Then it's important to screen and prognosticate certain family members, and we already know that there are certain myocilin mutations which are associated with a very severe phenotype compared to others. So when you are looking for a myocilin mutation, there could be very large families that you are looking for, and this particular mutation, which is 367 with arginine, is associated with a very large family with very high penetrance rate. We have found very large families with this particular mutation, and in such cases it's important that you sequence the family members to find as many members as possible with glaucoma. This was another interesting family where both the kids belong to the same family, had a CYP1B1 homozygous mutation. This was an arginine 390 histidine, which is associated with very severe type of a congenital glaucoma, and I operated both the kids actually. This boy actually came at 7 days of age, and this is 4 years down the line, and you can see that the corneas are clear, whereas the sister actually for some reason didn't come very early. The surgery was delayed, and she did not have very good outcomes. So I'm just trying to put the point that despite the fact that they have the same mutation, they come from the same family, they're operated by the same surgeon, the same technique, the outcomes are very different, primarily because the different times by which the children were brought. So this is not a classical case of a phenotype-genotype correlation, but it is a classical case of a delayed surgery in a child, which can change the totally. So to summarize, it is important for genetics to make a correct diagnosis, and decide treatment in some cases. It is also important because we can understand certain systemic association of some diseases which could be routine in a busy OPD. And then of course you can prognosticate certain diseases, especially when large families are involved. But one has to be careful and have some idea of the social concerns where especially in the type of scenario we are living in, where pinpointing the genetic mutation and from where it has come can have a lot of familial implications. So one has to be very careful with what kind of genetic counseling we'll give to these patients. Thank you.
Thank you, Dr. Vinay. And I think for want of time, we'll have Dr. Shailaja's talk, and then in case some questions are there for both of you, we can have.
Thank you to GGC and Professor Natarajan for giving me this opportunity. So I would be also talking on the similar lines as Dr. Vinay Gupta, and as a clinician pointing out the instances where genetic diagnosis and a genetic implications have helped me in managing my patients. When I joined work as a pediatric ophthalmologist, I was not aware that that genetic disorder is so prevalent among my patients. In fact, every other child I was seeing had some connection with a genetic genetic mechanism that was happening, either direct Mendelian disorder or some predisposition to a genetic condition or genetic situation. So when I went back and read about it, I saw that inherited eye disorders actually constitute more than 50% of legal blindness in children, and thus they have a huge economic and social impact. If you look at the eye, and these are only the monogenic disorders that I have, monogenic or polygenic disorders which I have mentioned, but not the ones where there are multifactorial disorders which also have a genetic connection. So it could be also complex because of chromosomal involvement, then direct DNA deletions, duplications, or even single nucleotide changes, plus and minus systemic associations. So how does a clinician try to apply this to their own practice? So this talk essentially gives us clinical examples of how application of genetics helped in diagnosis, prevention, or management of the disease, how it helped us understand the segregation of the disease in the family or establish a genotype-phenotype correlation. Also some clinical examples of limitations of genetic testing and counseling, some avenues for research in genetics for a clinicians, and the last part probably I'll skip because it's already been covered by previous two speakers. So I begin with this 26-year-old male who presented with a history of sudden loss, painless, gradual progressive, very slowly progressive, simultaneous bilateral vision loss at 18 years of age. When he came to me, he was 26 years and he was still finding answers as what is happening to him. His old records documented bilateral optic neuritis, for which he had received intravenous methylprednisolone at that time. His current vision was 1/60 in both the eyes, and fundus showed bilateral optic atrophy. So what was odd in this case? I could have easily dismissed this patient as a sequelae of bilateral severe optic neuritis, maybe a NMO positive patient. So what was odd? But he didn't typically fit into the typical optic neuritis, gender being male. Also, the slow progression even after treatment was not fitting into optic neuritis, and MRI being normal, although not unknown, but it's still a little odd. So can I do something more? That was the question. So only a simple thing like a family history, which was not taken before in this patient, revealed that there are two other siblings from the maternal side who have been similarly diagnosed as bilateral optic atrophy at a young age, optic neuritis at a young age, and which is very odd for optic neuritis. So definitely this was a hereditary optic atrophy, most commonly LH1 because it's more common, and also maybe X-linked optic atrophy. But what should I do? Should I examine the parents? Unfortunately, the other family members and parents were not present for examination, but we did genetic testing of the mitochondrial gene and did found a gene in the variation in the MTND4 gene, which signifies Leber's hereditary optic neuropathy. So why is it important to make this diagnosis for this particular patient? And taking this example, a genetic diagnosis helps us in prognostication, which would be very different for optic neuritis as compared to hereditary optic atrophy. dystrophies. The management are quite different. Of course, IVMP was really not required in this patient. Had it been diagnosed at the early time, he could have benefited from Idebinon prophylaxis to prevent involvement of the other eye, or maybe help in a little bit recovery also. And genetic counseling is definitely not applicable for an optic neuritis, but it's very relevant in an LH1, and especially the sister of and the other female siblings of all the affected ones need to be counseled for their children being at risk for this disorder. Family history and examination of parents is extremely important for all suspected genetic diseases. It can sometimes directly clinch a diagnosis. For example, a tapetoretinal sheen in female carriers of X-linked RP, posterior vise sutures in female carriers of Nance-Horan syndrome, and anterior sutures, sutural cataracts in carriers of cerebrotendinous xanthomatosis. So these can directly clinch a diagnosis and even not require a genetic testing. Coming to the second case, where the diagnosis was not very difficult. This was a 2-year-old male, observed lack of eye contact at 4 months of age, normal development milestones. There was a hyperopia with nystagmus, ocular digital sign was positive, and a normal fundus. So this was typical Leber's congenital amaurosis. But here, the mother was pregnant at this time, and they wanted to know the recurrence risk and also what is the chance of this baby having the disease, and wanted to prevent it. And he was clearly born of a consanguineous marriage. So we told them there's a 25% chance, but they wanted to test it. So at this point, genetic testing helped us to plan a prenatal diagnosis, and a similar mutation was found in the ongoing pregnancy, and the parents, plan to terminate the pregnancy. So here it lies in our, armamentarium. It's our duty to advise them for these kind of prevention strategies which are present. It is very difficult to live with one child with a debilitating and a blinding disorder, and imagine having 2 or 3 kids with the same disorder. So it's a duty to advise them to have this kind of a counseling done, and options of prenatal and pre-implantation genetics all should be given to the parents. And these are some examples of how phenotype-genotype correlation helps, especially in the retinal dystrophies. I'll not go into the details of this. Coming on to the next case, which was a 5-year-old male. This one also had a very similar kind of presentation, and here we suspected that this was a severe early onset rod cone dystrophy, and because of that he also had a hearing issue, probably an Usher syndrome. Here the diagnosis was just made because the parents wanted a genetic testing was done because they wanted a definitive answer. But lo and behold, what we found that he actually had NCL, which is neuronal ceroid lipofuscinosis, and what we were thinking that he's probably having a walking difficulty because of his vision problems actually turned out to be a CNS involvement of this patient, and unfortunately this patient succumbed a couple of months after the diagnosis, in fact. So again, it's the onus of the ophthalmologist sometimes to pick up these disorders and refer them so that these kind of things may not happen if the condition allows. So sometimes you just don't have any other things but these red flags, like any intellectual disabilities, any other neurological issues, some congenital anomalies, dysmorphic features, history of immunodeficiencies, history of recurrent pregnancy loss in the mother, and anything odd should clinch us towards some other problem going on in the child and not dismiss them just as an ocular disease. Coming to one more case where this 11-month-old baby girl, she presented to us with bilaterally small eyes since birth with nystagmus and very poor vision, born of non-consanguineous marriage, the first child of the parents, uneventful pregnancy, no developmental delay. So looking at the external picture, looked very typical of a microcornea with a coloboma, this almond-shaped cornea and pupils, but a deeper look revealed that she also had a PHPV kind of a thing where elongated ciliary process was there. The lens appeared to be inferiorly dislocated and also dislocated posteriorly into the vitreous cavity. I had never seen something like this. I also did a B scan, and here there was a PFV stalk, or the persistent fetal vasculature there, along with the coloboma. So this was a combination of microcornea, posterior megalolenticonus, a persistent fetal vasculature, and chororetinal coloboma. And I had seen this for the first time when I Googled it. It fitted into this MPPC syndrome, and very few cases have been described worldwide, and it has been postulated that somehow that incomplete closure of the embryonic fissure